Morning, everybody. It is time to get started talking about injuries. And also, I just wanted to let you guys know that we did hear back from the Arkansas Department of Health, and my quarantine has been extended until the 23rd of this month, so I will not be back in class until the 24th. They said it's because since my daughter and husband tested positive and we could not isolate ourselves from them, then our quarantine had to be extended 10 days past the end of their incubation period, which that's the 14th. So yeah, we're going to have to keep doing this for a little while. I'll have a video for you Friday. My husband's going to be my dummy, and we're going to video through some of the special tests, and then you guys will have to practice them on your own in class, watching our video, okay? But that is coming up. So today we're going to cover injuries. After we cover injuries, you should have time to study, and then we will be taking our anatomy quiz today. Okay, so let's get going. Okay, so contusions. We've covered these in different parts of the body so far. Contusions are just bruised areas, typically caused by trauma. Anything that occurs to the soft tissue. We can have bone bruises as well. However, in this region, typically when we're talking about contusions, we're talking about just soft tissue. Typically, we see these, honestly, all sports. It's not really a one sport more than another. Pretty common in almost all of them. Deltoid and traps, most common area. So deltoid, that top of the shoulder. Traps being this upper part as opposed to the rest of the trapezius. We usually see it more towards the upper section. Sometimes it can be so bad that you'll want to limit your movement. Kind of like how if you sleep on your neck a funny way and you wake up and kind of have that crick and you don't really want to move it as much in one direction. Similar to that when we have a really bad contusion. You could have them, they could occur to the distal clavicle, so like where it joins up with the AC joint. Typically when we see it happening in this area, we call that a shoulder pointer. It's very similar to the hip pointer that we talked about and we looked at when we were in that hip unit. Can cause numbness all the way down the arm, that tinkly, sleepy feeling. It can cause dead arm. A lot of people explain it, but it's when you get a hit right. So if your fingers are on your clavicle, the little soft spot that kind of indents just underneath of it, it's when you get hit right there. It's because all those muscles come through there. Your brachial plexus comes through there. So being hit right there just causes that dead arm to happen. But we call that a shoulder pointer. Now, as far as soft tissue upper, we see bicep tendon ruptures frequently. Now, technically bicep is shoulder and elbow, okay? So it is a both joint muscle, but it affects both joints. So, I mean, if we had a bicep rupture, it's going to affect elbow, it's going to affect shoulder, okay? If it's the long head of the bicep, it definitely affects shoulder because the long head, if you remember, comes into the glenoid labrum, but it affects both joints, okay? They are usually very, very visible, just like this top picture that has this yellow on it. Even really, really mild ones, you see a divot in the muscle. Now, if you happen to be watching when it happens, they look very similar to Achilles tendon ruptures when they pop and kind of roll up. This tends to look like that. If you weren't there to see it, you typically just see a divot where the muscle is gone. Now, as far as what causes it, our MOI is typically loaded movement. So think about weightlifting, pushing against a person, against the ground, against something. It's not going to be a non-weight bearing thing. Could be a direct blow, but a lot of times it's going to roll up, like I said, so you're going to get that divot, you're going to get like a ball. Typically you cannot flex the elbow, which flexion is bending upwards, so typically they are going to lose this action. If it's really, really minor, swelling's pretty common, pain, sometimes minor ones the person's not going to realize and they're going to keep going through it. You have to be really cautious with this because continuing on through that injury could end up leading to a more severe tear. So always double check and make sure that you're certain that it is some form of a tear as opposed to just a soreness. If they're moderate strains, then we're going to see some weakness with flexion of the shoulder or the elbow. Severe ones, super, super sharp pain. Then it gets achy as it starts trying to heal. They're going to be out for several weeks when this happens. Initially, we do Price, and if you remember, the way that we use the P to protect in the upper body is with a sling. So starting with Price, we will start mild stretching and strengthening at minimum 48 hours later. Typically, we wait a little bit longer. If it's very, very severe, we're going to immobilize the arm using a sling. Ice and refer to a physician. Could need MRIs, could need surgery. It just depends on the severity. So, sternoclavicular sprains and dislocations. Remember, this is extremely rare to happen, okay? MOI, though, is usually a direct blow. Could be bad padding over the clavicle, or it could be torsion. So imagine your arm is straight and it is behind you and it kind of gets pulled and twisted away from you. So think about like pull back and away. That could sometimes do it. But yet again, typically we're going to break the clavicle first. As all sprains, we divide them into first, second, and third degrees. It can become extremely problematic if the clavicle goes posterior to the sternum. So your sternum sits here, your clavicle sits here. If when it comes out of place, it doesn't sit on top or come forward, but goes backwards, that's when it gets really, really bad, because think about the things that are behind there. You've got blood vessels, your esophagus, trachea, so eating, breathing, that's going to be really big, bad ordeal. Immediate a medical emergency if this were to ever happen. But, I mean, there's a lot of things back behind your sternum that could be problematic if that went backwards. If it is just typical Price, so yet again, slings, immobilizing, you're going to have to moderate exercise, all of those normal things with a normal sprain or dislocation. I have had a soccer player that did a sprain to hers. She was the one that always did the throw-ins. And so imagine she would practice with weighted soccer balls, and opening her chest to do this action caused extreme stretch and strain on that joint. And she actually ended up spraining that joint. And she had to go through a course of like a steroidal treatment to try and calm it down. And we had to keep her from doing any kind of activities that opened the chest in that nature. So here is what this would look like, anterior dislocated versus posterior. So we're kind of looking down onto the person. Imagine, this little diagram, there's no head. We're kind of looking down. Typically, if it's going to come out, it's going to come out and come forward, an anterior dislocation. This posterior, where it goes behind, this is what we're talking about as being very, very problematic with those blood vessels, your trachea, and your esophagus. Now, AC ligament sprains, commonly referred to as a shoulder separation. If you look at this picture right here, this is textbook. This is what these look like. See how there's kind of a knot right here? Typically, this should be a smooth, rounded area where the clavicle meets the acromion process, okay? Now, typically the way that we see this happening could be a blow to the shoulder, could be falling on an outstretched arm. The majority of the way that I have seen these happen is when a person's arms are at their side and they're taken down, like they fall onto that side, and it compresses everything together. So imagine I'm holding a football, I get tackled, and my shoulder slams into the ground. When those two bones slam together, they have to go somewhere. And so usually the clavicle goes upwards, which tears those joints, which causes this joint separation. 3 grades, just like always. 1 is calm, 3 is the worst. Typically, point tender, pain with movement, not always a deformity with a grade 1, okay? That's where we hope to catch it, so that way we can start padding it, we can limit movement, we can do different kinds of things to protect it. A lot of times we can make specialized pads and covers that we can put over it to provide that protection so that we don't get another hit right on it. With a grade 2, there's a lot of point tenderness. Typically, we are going to see a deformity here. Could require surgery. It is going to need a physician referral to see for sure. Grade 3, this is considered a true dislocation. Both the acromioclavicular and that group of corticoclavicular ligaments, they're all ruptured. And so the clavicle is pointed upwards. It is lifted up. Lots of pain. I had one athlete do this once, and they definitely did surgery to have to fix his. They had to tie it back down. He was out for a very long time. Ice early on, you got to immobilize. Then it's going to be getting back range of motion and flexibility. That's going to be the top thing, because without that joint functioning, you're going to lose overhead activities. Okay. So got to get movement back. A lot of times they're actually going to refer them out to PT as well as working with us on this one. So typical shoulder joint sprains. Usually we see this on a first shoulder injury, like when nothing else has ever happened to the shoulder before, because typically once we start seeing shoulder injuries, we start having more and more problems because the joint is so non-stable. Once you hurt it once, we're going to continue to see things happening. So typically our MOI is forced abduction. So imagine forced being yanked this way, or external rotation, okay, or a direct blow. So typically those are what causes this issue right here. Otherwise, the infraspinatus and teres minor, they are usually the ones that control external rotation, so we need them to be really, really strong. A lot of times they'll complain of pain in the back, or that when they move, it feels like it's pinching. Those are really common symptoms that athletes will come to you and talk about. Like I said, pain during movement, hurts to touch. Typically here we're going to do priced cryotherapy. So think about like game readies, ice massage. Ultrasound can be beneficial here, not in conjunction with the ice, because ultrasound is a heating. Lots of range of motion. So lots of having them lie down on the table. We're going to have the arm. We're going to be moving through different motions. I'm going to show you through some of those things when I do the video with my husband for you on Friday. Resistance exercises. We have been covering resistance exercise. We're going to continue to cover it, but you guys have been doing a really good job of understanding those steps. So make sure you're prepared for that when we get there. And then there's going to be a lot of functional training before they go back, which if you remember, functional means it's sport specific, making sure that you can actually do the skills required to return to your sport. All right, let's talk about dislocations. So shoulder dislocations typically occur anteriorly. Big key, anteriorly. Now, bad thing is, once you do this once, you're typically going to do it again. Yet again, super unstable joint. Therefore, once you knock it out of place once, things get stretched out, and it usually happens again. So, could be a direct blow. Okay, so I've seen kids that had this happen, getting tackled, coming down, and landing on it in a basketball game. Could be a direct blow, but the most common position that we see this happening is when the arm is externally rotated and it's lifted up. Okay. In this position, if there's any force backwards, the head of the humerus is so simple to come forward to pop out of place. So think about, I've seen basketball players go out doing rebounding stuff, getting caught up with their arms and their arms getting pulled backwards and causing dislocations. I've seen it in baseball and softball players, tons of football. It's this position, abduction, external rotation. But like I said, the head of the humerus, once we're here, it's forced forwards and usually it falls downward. So if you look here, here is our glenoid fossa, and the head of the humerus is in front of it and down below it. Usually it sits just below the coracoid process when it comes out. This is going to tear ligaments. A lot of times it's going to tear tendons. The joint capsule is going to get torn, and then it may or may not tear the labrum. MRI is going to be needed typically to see that. So When they dislocate it, I know that this is just a drawing, but you do see a very weird representation of the shoulder. Now, if they wear pads for their sport, you're not going to see that, okay? There will be nothing. You're not going to be able to see it. But if you put your hand inside their pads, you would be able to feel that there is not a rounded shoulder here. It's gone because the head of the humerus is essentially down here. Okay, so it is gone. Now, they're also typically their arm hangs really dead to their side, or they hold it with their good arm and they hold it in front, just like this picture. Almost every single person I've ever had dislocate comes running to me looking just like this picture. Good arm is holding the wrist of the dislocated arm kind of across their stomach, trying to cradle it. And that's basically what this is just talking about. Lots of pain. Usually they pressure. I've heard a lot of the athletes talk about the pressure that is involved there. So treatment. Big thing here. We do not, as athletic trainers, forcefully relocate shoulders. We don't. What we can do is that we can tell the athlete what to do in order to see if gravity can bring it back into play, which involves having them lean over, let the arm that's dislocated dangle in front of them, and let them relax, and that will usually be enough to pop it right back into place. On rare occasions, I've put the person's helmet or a water bottle in their hand of the dislocated arm to give just enough weight that when they lean over, that will pop it back into place. If that doesn't work and it does not come back in, they need to immediately be referred to the ER for imaging and relocation. The reason we have to image is because they need to see, are there any fractures? Is there any blood vessel involvement? Is there any nerve involvement? Is there any tendon involvement? Because if we just yank a shoulder back into place and any of those things are involved, we could be pinching them off once the shoulder snaps back into place. You saw what happened to Inky Johnson. If we disrupt that blood flow or that nerve flow, it's gone. They're going to lose the arm. Now, once it's back in place, sling is needed. Okay. We are typically going to bring it up, hand up. That way they're internally rotated. Arm is in a sling. Sometimes I've even wrapped an ACE wrap around them to make them stay in that position. Now, we like to start doing isometric activities and strengthening as well as range of motion pretty early on, as soon as pain will allow. But you're going to have to limit this action because this is the way that they were when it went out of place in the first place. So we're not going to take them back into this position to stretch them. We're not going to do it. Typically, first-time dislocations, they need to go to the doctor regardless of if you put it back in place or not, because it needs to be documented that this is happening. After that, usually they'll have a plan in play. They've been following PT. They've been doing something of that nature, and it may not always be required. I will tell you that I've worked with 2 different doctors, one surgeon, one was not a surgeon, that told me that the way that they view dislocations is that they look at 2 main things. They give the person their fingers and have the person squeeze as hard as they can. So I'd give you my fingers, and with each hand, they would wrap up my fingers and they would squeeze as hard as they can. And I am judging, do they have equal strength on both sides? Usually we would do that, and then we would put our hands on their shoulder and have them shrug up while we push down. Yet again, just seeing, is there equal strength? And then the surgeon said he would have them give him a high five above his head. Because if you can get up here, then that's full range of motion. So he tested strength and a high five above his head. If they could not do those activities, he would not return them to play, regardless if it was the 5th dislocation or the 1st. So I've always kind of followed that ever since then, is that I would test grip strength and shrug strength, and then I'll ask them for the high five. Now, posterior glenohumeral dislocations, look at this, 1 to 4.3% of shoulder dislocations. These are not common. So imagine that your arm is forced, adduction is in, and then internal rotation. This is not a very common thing. Maybe if you fell in front of you, like if you reached across you as you were falling and it kind of bent inwards, perhaps, but it's just not as common. Lots of pain, lots of disability. This one is a whole lot bigger of a deal. Typically, we are sending this person straight in. It's not going to be reduced by a nice little gravity thing. It's going to be reduced under anesthesia. It's going to be reduced, perhaps even surgery if needed. Okay, and then like I said, if they have recurrent dislocations, if you remember, a subluxation means that it comes out a little bit, but it goes right back on its own. These become very, very common with repeat dislocators as well. Macro trauma means that there's one or more big traumatic situations. Atrauma, that means that there is so much damage and there's so much laxity in movement that it will just come out of place. I had a football player that his got to the point that he could be lying in bed asleep and would roll over. Atrauma, just rolling over in bed, and his shoulder would come out of place. He would wake up with it out of place. He had to have a major shoulder surgery to tighten all the ligaments, repair his labrum. It was pretty bad. And then microtrauma is instability that's caused by repetitive use. This is typically what is the most common type. Biomechanics could be a part of it. Say you've got a person with a really bad throwing mechanism. Maybe that could be leading to shoulder problems. Bad tackling form, that could also be a part of it. Like I said, symptoms of people that do this over and over and over. Clicking a lot of times. So think about like a torn labrum. You're going to hear some clicking. They may feel it. Pain. They'll get dead arm, which is that weakness, that numbness, because it happens all the time. And impingement, which if you remember me talking to you about impingement, that was when we had swelling in here and it would pinch off the nerve flow and you would end up with a numb hand. Treatment with recurrent dislocations, they're going to have to rest it after each one, PT to strengthen everything, working on range of motion, and then usually all of them I've dealt with, they had to have surgery at some point. All right, we've talked about bursitis quite a bit. It's the same no matter if it's in the knee, hip, shoulder. Subacromial, most commonly affected. That's really the biggest thing that I want you to know here. We know what the signs and symptoms of bursitis are. We have seen it. We've talked about it. I want you to know subacromial, most common type. And if it is irritated, you are going to get positive impingement test because you're going to get that numbness because that is underneath that tunnel ligament. So there's the tunnel ligament. It's literally inside the tunnel. It's going to pinch everything off. Let's see. Let's go ahead and stop here, and then we will pick back up Friday. We'll finish out injuries Friday, and I should be able to have that video for you of special test.